And I'm not going to leave any of the 3 people who already talked without comments on their talks, inshallah. They were really beautiful talks. Now we're going to go down to life and see how things occur. Where's the... How do I move forward this one? Yeah. Okay. Thank you. Can I do it from here?
Can use it from here, yes.
من هنا ما?
All space.
Okay. So, aneurysms of the interatrial septums. This is a classical aneurysm. You were shown really nice ones, and like it was stressed to you, measurements is important, and that's how we do the measurements, and anything above 10 will fit into the diagnosis of aneurysm of the interatrial septum. If you're lucky, you have to put color and try to see the shunts like you've been told. And if you're lucky, you will see something. But most of the times, you don't see much. And if it is really strongly suspected, for example, a patient sent to you with a cryptogenic stroke or something like this, you have to do a bubble study. But I will discuss with you a bubble case that happened to me last week at the end if I have time. And an interatrial aneurysm does not have to be a congenital one. We are all practicing in a part of the world where we see a lot of mitral stenosis. And this is a really, really nice case where you can see there is severe mitral stenosis and the interatrial septum, which might have started being thin, has been stretched so much that it has become very aneurysmal. And when you look at it, it was even causing obstruction into the right atrium. And if you look at the color, you can see how the aneurysm, so this is all left atrial part, but the aneurysm is interfering with the flow into the right atrium. So it's fun. You can see it when it is not congenital. Like I said, you should try by color to look into the shunt. And this is a very redundant, again, usually this makes it highly probable that they might have problems. But if you put color, you can clearly see that you have a clear shunt. Now you could ask yourself, is this an ASD? Is this fenestration into the thinned interatrial septum? Sometimes it's very difficult to answer this question until you do a TEE. And it's the same patient, you even manage to do the color and to do the Doppler, and usually you have systolic and diastolic flow across the interatrial septum. And sometimes it could be fun to demonstrate. You've already seen 2 cases from 2 speakers about what I'm going to show you, but this is the inflow of the right ventricle, and you can see this cystic structure in the middle. You have to admit it's the nicest of the 3. And this is, don't start thinking of hydatid cyst and all those funny things. Just wait until you look at the 4-chamber review. And this is our interatrial septum. Like Dr. Sami said, we are cutting it across the way, and it looks, when I cut across here, okay, it looks like it is a circle in the right atrium. You can again have, like you've been told in the first talk, that you can have an interatrial septum aneurysm with an ASD. And this is a case where you can see that the interatrial septum is quite aneurysmal, but I do see here some flow which is very, I cannot ignore it, somewhere around here. And you do some more views, and definitely there is a flow across this area. And when you do the still picture, this, again, is this an atrial septal defect, or it is thin part of the aneurysm? You need to do a TEE. I did some extra views, and I did the Doppler, and there's no doubt that there is a flow. So we did a TEE, and the TEE showed that there is, in this area, and you're going to see more than one area, but there is discontinuity, and there is another discontinuity here. And when you do color, it is obvious that this patient through the interatrial septum has flows at 2 points here and there. And this is, again, a still picture. This is the explain. You can see it, the aneurysm in 2 parts, but this is what we are interested in. And there's flow here and flow here. Again, you can see 2 flows, and it was decided that they will be closed. So measurements were done, and he had a reasonable rim on the aortic side. To me, it looked small, but the interventional said it is okay. So they managed. They tried to close it, and it was not a good one. You've already seen one of my colleagues demonstrating this. So still with some flow, and this patient ended up with another device which managed to close the area well. So interatrial septum can be by itself, it can be with ASTs. What about the PFO? Most of the time it is referrals that point towards possible diagnosis. A young or old patient with a mild or more severe neurological insult, and it could be an incidental finding by color flow imaging. Sometimes you can only see it in the subcostal view. We teach all our juniors and technologists that's the best view, and you can clearly see that there is a tiny jet, and this is a still picture of it. And this is another case where you can see a very, again only in the subcostal, very tiny jet of what looks like a PFO, and this is the Doppler of it. Bubbles can be done, a bubble study can be done, and like Dr. Sami said, within 3 beats, and this is immediate appearance of the bubbles on the left side, so paradoxical shunting, and this is the still frames to show you the bubbles. You can see it by TEE, of course, and this is a fantastic case of a patent foramen ovale. Look at the distance. One of our colleagues went crazy about it, and he did all the measurements under the sun. But the interesting thing to see that there are already bubbles on the left side. So this patient does not have only left to right shunting, he also has right to left shunting, and you can clearly see the right to left component of this shunt. Of course, you would expect from left atrium to right atrium, and he is now to the right. And we did again bubble study, and it was obvious that he has paradoxical right to left shunting. That's some of the measurements that my colleague did. This is the color flow to show you both the right to left and left to right shunting. So it is interesting, but they are not without problems, PFOs. And this is one of the worst cases we came across. He's a 58-year-old man, had multiple TIAs 3 years earlier, had a stroke with mild residual deficit. TEE showed a PFO, although he was hypertensive, diabetic, and he had other causes to have the stroke. His wife, who was a nurse, insisted on him to have this closed, so it was closed. He presented recently, around that time. He had below knee amputation because of a diabetic problem, and he had fever with positive culture. And look, by the transthoracic, this is the device. Sometimes you can see it in this view with certain angulations, and there is already a mass on the left side or the left atrial surface of the device. So you know most probably the device got infected. So we went ahead and did some more views, no doubt. Now this is a mass. But in the other views, we could not see it. Remember? It is possible that you don't see it in all the views, so we went for a TEE. And this is his device by TEE, and the device is coated all over by a mass. And then you do tilting, and there's this free moving mass on the device. You do some more views, a lot of masses on the device, again, coating of the device. And this is the 3D, this is the left side, left atrial view, and this is the right atrial view. Remember, most of the mass was on the left atrium. He refused to have anything done to him. He's had it with the hospitals and disease, so he remained at home. His wife was giving him his antibiotic, and actually he managed to do well with no problems. And we've seen him recently, he is doing well. With still his device, he even refused to have a repeat TEE. And things can occur unexpectedly. This is a 45-year-old woman recently diagnosed with cervical cancer. She was awaiting her surgery, but she became very depressed with the diagnosis, and she hardly mobilized in bed. The day she presented to us, she had chest pain. Her husband, or I don't know whether it's her brother, brought her to the hospital, and she collapsed at the door of the ER. I think she was a lucky woman. She was intubated. And even looking at the transthoracic, you can see this mass, very tubular, very thin in the left atrium, passing through the, trying to pass through the mitral valve. And we did her right atrium, and this is the popcorn appearance. Everybody would tell you that this is most probably a thrombus. This lady hardly moved at home, but people were saying, well, she has a cervical cancer, and this could be cervical metastasis. Ya Ammi, think of the things which are more common. And they started arguing, shall we give her TPA or not? And the TPA people won, but let me show you what this lady had. She had a mass in the right atrium, she had a mass in the left atrium, and there is no doubt, we did a bubble study, it was positive for a PFO. We even managed to get the Doppler, and this is her thrombus, straddling the area fossa ovalis. You cannot see anything more beautiful than that. So there is a mass passing through the PFO to go to the left side. She was given TPA against some people refusing to give it, and this is exactly 24 hours later. She did not have any more masses, neither in the left side nor on the right side. In case you wanted to ask me, she had a stroke, a very small stroke, but she was left with a very minimal deficit. She managed to do her surgery. I don't know what happened to her. So we cannot let the puncture of the interatrial septum get away with it, Dr. Hani. So let's show you this. Actually, there are really two cases. I'll try to finish quickly. This is a 64 years old Australian nurse with us. He had in the past 2 ablations because of atrial fibrillation and atrial flutter, but he had recurrence of his atrial fibrillation, and he was very much symptomatic with it. He asked for ablation again, so they got him in, and this is them trying to cross the interatrial septum. I was just doing the echo and following them as they're speaking, and one of the doctors said, I don't like this view. I want to recite my line. So he went and did that, and look what happened. Just as he removed the catheter or whatever the line, a mass appeared at the site where the thing was. We did extra views, and it was obvious that he has developed a thrombus at the area where they were trying to do the puncture, and of course the case was aborted. He became very much worried. He refused to have another trial after proper anticoagulation, and we stopped at that level. Actually, he has left us. Just 2 minutes, please. But the last case is even more interesting. This is a 25 years old woman diagnosed to have supraventricular tachycardia, the atrioventricular reentrant tachycardia, nodal reentrant tachycardia, and she had ablation of the slow pathway on the 9th of January 2018. And this is her echo just before she went for her ablation. Beautiful parasternal long axis view, beautiful four-chamber view with no problems. So as I said, she was diagnosed, she had the ablation, and next day, on the 10th of January, she had left loin pain and noted to be short of breath. Echo was requested immediately to exclude a pericardial effusion. And CT was ordered, and look and behold, the CT showed bi-lung pulmonary embolism and multiple wedge-shaped hypotense areas in both kidneys. So obviously this lady had a problem both on the right side and systematically. And when we did the echo, this is her normal ones, and she has this huge mass in the left atrium. You can see it even better here. And remember, her echo was completely normal just few days earlier. You can see the mass on the right side. You can see the mass now, a mass on the right side in the proximity of, you could say PFO, frankly, but we know she didn't have this mass before. And this is again showing it across from the right side to the left side. And again, this is the best view to show that they were connected together, but the 3D showed that most beautifully in the next. So most probably, this is what I want you to see. You can clearly see the thrombus going across the interatrial septum. Most probably related to her puncture that she had for the ablation. So in summary, all these conditions that has been discussed with you earlier, the PFO, the interatrial septum, even the puncture, for all these procedures can be associated with complications. Thank you very much.